This is our final session in the 340B for Viral Hepatitis Program series. And as you all know by now, my name is Erin Fratto. I'm a public health consultant, former health department prevention manager, and 340B authorizing official and primary contact. I've navigated the 340B program for years, and today is all about 340B and health equity. We're going to cover a lot of content today. A lot of really important topics will be discussed, and hopefully I'll be able to tie them all together in a beautiful gift-wrapped 340B package for you by the end of the presentation. And we're going to go over a review like always, dive into some health equity concepts, viral hepatitis inequities, and then really discuss 340B as a health equity tool. We'll also identify 340B health equity action items, and then we'll also open the floodgates for future 340B technical assistance requests. So first off, it's pop quiz time, right meow. Let's take a quiz, right meow. Let's see if I can launch my poll. Okay, can everybody see, hold on, wait, launch polling. Can everybody see the poll? Anybody?
You'll see the poll.
Maybe chat that you can.
Confirm in the chat.
Make sure I didn't screw my technology up.
Yes, thank you.
Awesome, cool. So your questions, first question, how can you determine if a grant is authorized by Section 318 and gives 340B STD designation eligibility? Second question, how many 340B registration periods are there every year? Third question, health departments are in charge and liable for all 340B STD covered entities in their jurisdiction. And then number 4 on that list, what is not a 340B compliance consideration? And I see only 3 of you have voted. So everyone engage with us and give your best guess. Give a few more seconds, get some votes in. We're up to 27% have voted. You can do it. We can just get to like 60% voted. Oh, we made it to 50%.
Yay. How's it looking?
We're at 54%. Should we call it?
Let's do
Just
it.
for time? Okay.
Yeah.
I'm going to end polling. And can I share results? Can you see the results?
I do not see the results.
Dang it.
I don't know if folks can see the
It
results.
says attendees are now viewing the poll results.
Maybe I see results. Oh, people are saying they see results.
Okay, yay! we were just talking about, you think by the 5th webinar that we'd be okay with Zoom functionality. We're not. Okay, so first question was, the correct answer is C. Every NOFO has a statutory authority listed in it. You can search any NOFO and find this information. You have to be proactive. Nobody is going to notify you that you have grant funding that is 340B eligible. Don't wait on Office of Pharmacy Affairs. Don't wait on HRSA. Don't wait on CDC. It's not going to happen. Take care of yourselves. Second question, the correct answer is 4. There are 4 annual registration periods every year, the first 15 days of every calendar quarter. It does not matter if they're business days or weekends. It's the 1st through the 15th of January, April, July, and October. The register button is on the Office of Pharmacy Affairs website, is only accessible during these open registration periods. Office of Pharmacy Affairs takes up to 3 months to verify registration and activate your registration, and you may not purchase or dispense 340B drugs until registration becomes effective. Number 3, correct answer is false. Every covered entity is responsible for themselves. Health departments are supportive and guiding partners for their covered entities in their jurisdictions who are operating under their grant number, but there's no mandate from HRSA or CDC that you are authoritarian figure in this relationship. Number 4, correct answer is D. All of these are compliance elements in the 340B drug pricing program. So excellent job, everyone. We're gonna stop sharing results, get rid of that. And the previous sessions are recorded and are available on NASTAD's YouTube channel. The links are there and of course are shared with you. And in summary, the 340B drug pricing program is a federal program that is meant to stretch resources as far as they can go. Eligibility is dependent upon receiving federal funds that are authorized by certain sections of the Public Health Service Act. Patient eligibility is broken down into 3 parts. The covered entity has an established relationship with the individual and maintains records of the individual's healthcare. The individual receives the healthcare service from an employee or paid contractor of the covered entity, and the responsibility of that care remains with the covered entity. And the individual receives healthcare services or a range of services from the covered entity, which is in line with the scope of the grant, the intent of the funding. And with that very short and condensed review, I'm going to pass it over to Isabel, and she's going to ease us into equity.
Ooh, I like that. Ease us in. Okay. So to start off our discussion, I'm going to outline a few expectations in our thinking and collaborating for the remainder of our time together. This framework that we can see here on the slide is adapted from a workbook developed by Tema Okun at Dismantling Racism Works. First, let's pivot from either or thinking to, which is really seeing incidents of inequity as isolated events, to systems thinking, meaning to understand context and intersectionality, seeing patterns and holding contradictory thoughts and feelings simultaneously. Next, let's work on strengthening collaboration, specifically recognizing that this work requires taking the time to build relationships based on trust, focusing on building a bigger pie instead of fighting over a slice, along with mutual support and promotion of our work. And finally, community, specifically recognizing that to change everything, it takes everyone, and we must work from a movement lens. Next slide, please. On the slide here, we are looking at the definition of health equity from UCSF and the Robert Wood Johnson Foundation. That defines health equity as everyone having a fair and just opportunity to be as healthy as possible, which requires removing obstacles to health, such as poverty, discrimination, and their consequences. And the second paragraph we're looking at is from the National Collaborating Center for Determinants of Health, which states as part of their Let's Stop Racism and Health Equity work that public health needs to adopt critical, decolonizing, and anti-racist approaches to understand, disrupt, and transform the public policies, social and institutional practices, and cultural views. Next slide, please. Here we are looking at, so on the left side, the definition that is more technical in terms of public health. Oh, sorry, got an email. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. And to the right, we see the definitions, the separate definitions to make a distinction between health equity and health disparity. Health equity is the ethical and human rights principle that motivates us to eliminate health disparities. And disparities are worse health in excluded or marginalized groups. And it's how we measure progress towards health equity. Next slide, please. So this is one of my favorite figures that has come out of last year, 2020. The figure shown here is the revised social determinants of health framework created by Professor Rukaija Yerby in 2020, which includes the root cause of racial health disparities in a multi-layer approach. So Professor Yerby based this model on the public health critical race praxis and the work of social epidemiologists that specifically note that American systems are structured in racially discriminatory ways that reinforce discriminatory beliefs, values, and distribution of resources. An essential change to this framework, if you can hit there's an animation on there. There we go. That needs to be highlighted for us is the explicit distinction to replace health with public health, as this allows for health to be shown as an outcome. So hit the neck, there we go, from these key systems. The intention in reviewing this framework is to outline the root cause and the tool that leads to the structures of these systems that prevent health equity, so that us as public health can make the connection to then work to end these inequities. So next slide. All right.
I should unmute myself before I start talking. Thank you, Isabel. That was excellent. So let's transition now and bring our viral hepatitis lens to this. Despite successes in the fight against viral hepatitis, there remain significant racial, ethnic, and socioeconomic disparities in the incidence and prevalence of viral hepatitis outcomes, and healthcare access and quality. In America, the type of healthcare a person receives is significantly influenced by their race, gender, income, ability, and geographic location. Liver disease and cirrhosis remain the 9th leading cause of death in the US. Highest mortality rate from liver disease occurs among Indigenous communities. Black people have a disproportionate Hep C burden and are twice as likely to be infected with Hep C when compared to the general US population. Black folks also have the highest rate of hepatitis B infection, but the lowest Hep B vaccination rates. They also are living with Hep C and are less likely to receive treatment than their white counterparts. And these disparities are independent of healthcare systems and payer status. Hep C non-treatment is also associated with age, alcohol dependence, drug use, and medical and psychiatric comorbidities. Tell us in the chat what health disparities, what hepatitis health disparities are on your radar and what you're passionate about. I would love to hear what you all think about this as we go along this content. And most of these stats aren't new to you, but I feel that reviewing them in the context of 340B programs is beneficial, especially with so many of you supporting correctional facilities, providing them with 340B eligibility. Viral hepatitis infection is high among individuals experiencing incarceration. The prevalence is estimated anywhere from 13 to 47%. That means that half of incarcerated individuals may be infected with viral hepatitis. The Bureau of Justice Statistics reports that 75% of state prisoners are white, while 38% are Black and 21% are Hispanic. There is a huge disparity in incarcerated populations. Black Americans are incarcerated in state prisons at a rate that is 5 times higher than whites. In Iowa, Minnesota, New Jersey, Vermont, and Wisconsin, this disparity is more than 10 to 1. Maryland's prison population is 72% Black. This tops the nation. Maryland takes the prize. In Oklahoma, 1 in 15 Black men over the age of 18 are in prison. These are horrifying statistics, and the fact that hepatitis is more prevalent in these populations means that there's a disparity on top of a disparity. The criminalization of drug use is also disastrous. Every 25 seconds in the US, someone is arrested for possessing drugs. 1 in 9 arrests are for drug possession. That amounts to 1.25 million arrests every year. This is 4 times as many people are arrested for possessing drugs as are arrested for selling them. Now, by congressional intent and design, the 340B drug pricing program is intended to stretch limited federal resources to reduce the price of medication for patients and expand health services to the patients and communities they serve. Healthcare access and quality is a social determinant of health, like Isabel discussed, and the 340B drug pricing program is designed to improve healthcare access. We need to have our eyes wide open to the existing health disparities, acknowledge the institutional racism that perpetuate health disparities, and engage in anti-racist work to correct what we can. Understanding the 340B drug pricing program is a step in that direction. We'll talk even more about actionable steps that you can take as program administrators in this work, but just know that knowledge is power. And once you know better, you do better. The 340B drug pricing program is an opportunity to start health equity conversations and bring anti-racism work to the table. The 340B program can and should be used as a tool to address health disparities and implement racial justice work. It should be used correctly. So again, just take this time for self-reflection. What does your organization or agency do to address health equity? Does your agency have health equity directives, projects, or programs? How are you addressing health equity in contracts and agreements, and more specifically, 340B contracts and agreements. And with that point of self-reflection, I am going to invite Ricardo to the stage. Hello, Ricardo. If you wouldn't mind introducing yourself, and then I'm going to ask you a question, but I'll wait till after your introduction because that's a big question.
Sure. I'm Ricardo Fernandez. I work at the Arizona Department of Health Services in our HIV and hepatitis C programs.
Awesome. Thank you, Ricardo. So I would love for you to highlight what you or your organization or any of your covered entities do to incorporate health equity initiatives and strategic plans into the work. And how do your 340B programs and covered entities use savings or revenue to address health inequities and social determinants of health? It's a very all-encompassing broad question, and I can ask it again if you need it broken down.
Yeah, no, that makes sense. Thank you, Erin. So broadly, the health department does have health equity plans on several levels. Our overall health improvement plan for the health department as a whole incorporates a significant health equity component in the new version of that plan that will be coming out. So it's something that's broadly supported by the agency as a whole. It isn't something that's just purely an initiative of our program. There are some limitations to that. We are in a more conservative state, and there are things that have to be addressed in line with the expectations that we have in our state of the health department. But that is a component of our overall agency health improvement plan. And then more specifically in our ending the HIV epidemic planning, in our integrated planning for HIV, our hepatitis C elimination planning, in all of that, we've tried to build in significant health equity components and into our planning efforts, particularly into efforts of including communities that are disproportionately impacted by HIV and by hepatitis C into the planning process. You know, that historically, I think sometimes that was a little bit more inconsistent in how people were involved in planning, and we've really made a concerted effort to concretely engage people in ongoing community engagement, and not just feedback like when we need concurrence or to put the stamp of approval on something, but to have ongoing feedback and ongoing involvement through the extended planning processes for all of our HIV and hepatitis C planning. Our covered entities have less specific health equity initiatives. They are sort of focused, a lot of our programs are focused really, to be frank, not on really addressing issues of health equity, but sort of responding to the after effect of the health disparities that already exist and trying to do what we can to mitigate them to the degree possible. They're not really proactive responses to things. It's by the nature of how our programs work and the resources that we have to dedicate. And that's mostly what we partner with the covered entities that we sponsor with a 340B status, that they implement programs that really try to address the hepatitis C health disparity and treatment access issues of specific communities by broadening access to treatment and supportive services around treatment, to make it easier for people that, because of existing inequity built into our healthcare systems, would normally not have gotten care, but that with those programs, they do get care, if that makes sense.
Yeah, that's a really great summary. Can you talk to us about maybe some measurable outcomes that your covered entities share with you to demonstrate the access that's been increased, or you know, work towards that inequity in access?
Yeah, so probably the most straightforward metric that that we track is the number of folks that are treated and achieve SVR for hepatitis C. So before we implemented the hepatitis C programs with 340B, we had numbers of folks that were being treated. So for example, with one of our partners, we partnered with the Arizona Department of Corrections, Rehabilitation and Reentry which is the state prison system in Arizona. And before our partnership, they were treating on average between 200 to 250 people with hepatitis C and curing folks in the system. With our agreement with them that reduced drug pricing, we were able to get an agreement that would increase that to at least 500 people. And they are actually on track this year to exceed that target and to treat perhaps as many as 600 people in the state prison system. So that represents, almost a tripling of the folks that are receiving treatment for hepatitis C, which they otherwise would not have received without the 340B program. And those are folks that also, oftentimes when they do get released from the state prison system, they would often be dependent on our state Medicaid, which still has a few restrictions on access to hepatitis C treatment. And obviously, once you're released from prison, hepatitis C treatment is not your top priority. So I think being able to treat people before they have to experience even more treatment barriers has been very helpful. So that's one way that we've tracked things.
Awesome. Thank you. And you mentioned that just the public health system inherently is reactive and not proactive. Can you talk to us about some of the barriers your jurisdictions in your jurisdiction that your covered entities face when working towards addressing health inequities?
Yeah, I think, excuse me. Yeah, I think some of the barriers just have to do largely with resources. I'm sure this is the experience of a lot of folks. Like, our hepatitis C funding in Arizona is $315,000 compared to Ryan White funding, which is over $30 million. There's a lot more people living with hepatitis C. So just the resources to provide the support systems are a barrier. So 340B can help bridge that to some degree, and to help with things like transportation, service coordination, insurance issues, and all of the other barriers that often go with accessing hepatitis C treatment. So those are some of the things that our covered entities face, and that the persons that they serve face as well when they're accessing care. But I think that, in a properly functioning 340B program, the program is fundamentally redistributive. So we can, the external clinics that are, because we have also partnered with a clinic that works with folks in the general public, and we try as much as we can to leverage the program income that's collected from insured clients and paying clients to develop patient navigation, develop transportation, and develop other resources to help address those treatment barriers that people face to getting care.
Thank you. We really appreciate you bringing the real world perspective to this session today. So I just thank you so much. And Ricardo's going to be on for the session today. So if anybody has questions specifically for him, or we want to do some connecting, we will have time for that later in the Q&A. So thank you so much.
Thank you very much, Erin.
All right. I want to take some time to explore 340B Health's report. This report was released in February of this year, and it discusses best practices from the field to look at how hospital systems are using 340B to address health disparities. Hospital systems are utilizing the 340B program to work towards health equity. These same principles can be applied to health departments and their subgrantees and should be kept in the front of your mind when designing, implementing, or improving 340B programs for Section 318 grantees. 340B hospitals serve patient populations that are more diverse than other systems. They provide the safety net for people living with low incomes, and 340B patients often face greater health challenges and barriers in accessing care. Does all of this sound familiar? It should, because these are the same demographics that are also experienced by viral hepatitis programs. There's so much overlap here in the patients that are served by hospital systems as well as public health programs. Institutional work that is outlined in this report includes health equity strategic plans, training in cultural competency and implicit bias, increasing diversity in leadership and governance. Data collection and performance measurement work is included in this report. Lots of hospitals are increasing the collection of data on race, ethnicity, primary languages. This data allows hospitals to really stratify the quality and outcomes and patient satisfaction data to identify disparities. The disparities uncovered by hospitals also lead to targeted interventions being implemented. Screening for social determinants of health also allow hospital systems to partner with advocates in the community, provide referrals, and link folks with resources, including food, transportation, employment, and housing. Much of this work is supported by 340B savings, revenue, and income. 340B medications are deeply discounted, saving millions of dollars for hospital systems, which means budgets can stretch farther and financial resources are freed up. So if something wasn't seen as a priority before, these medication savings now provide more resources and can now be prioritized. So Isabel will drop the report in the chat for you all to be inspired by, but I wanted to pull, oh, awesome, thank you. So she's already on top of it. I was struck by a few examples and I really wanted to bring them into today's session. Almost all of these hospitals have health equity strategic plans, initiatives, or pledges. Most also have health equity built into their visions and missions. Virginia Mason Memorial has a health equity guiding team. Brigham and Women's Hospital has an equity response team. And using their 340B designation to allocate resources, these hospitals have committed to workforce diversity and inclusion with goals of recruiting and retaining employees of color and providing a pathway for education, promotion, and higher compensation. There's also implicit bias training being offered among all of these hospitals as well. Data systems have been designed, implemented, and/or improved among all these hospitals. Data dashboards have been created with data being closely analyzed that can quickly identify health disparities in clinical data and discriminatory experiences among satisfaction surveys. And that leads to improvement of services and care. So first you have to identify the problem and then you need to respond to the problem. And one story that stood out to me as a mom and also as a human was that in one hospital, nurses and care technicians were not washing Black children's hair as often as that of white children. When questioned, it turned out that white staff did not know how to care for Black children's hair, and they also didn't have the right hair care products. This hospital developed a video to train caregivers on how to wash, comb, and condition a Black child's hair, and worked with the supply chain to obtain the appropriate products. In another example, a child life specialist discovered that Black children were not drawing pictures of their families because they didn't have the right color of crayons. Crayola makes a multicolored crayon packet that hospitals can now stock. None of this was done before. This is the racism and discrimination experienced by Black communities accessing healthcare every single day. How simple the solution was to educate about hair care, provide the correct products, and buy the right crayons. This should have been a priority before 340B, but 340B gave more resources. It allowed more funding. These changes were made possible because the money saved or the revenue generated from the 340B drug pricing program. So I just want you to keep that in mind as we're talking about viral hepatitis program. So I'm not so delusional that I believe the 340B drug pricing program, viral hepatitis and prevention program administrators can single-handedly take down institutionalized racism and solve long-standing health disparities. But I do believe that you all are passionate, you all value human lives, and you want everyone to achieve health and well-being. Let's take a quick check-in on where you're at and launch another poll. All right. The poll should be launched. Are you privileged? Multiple choice. Regarding 340B, you are in a unique position to leverage opportunities and to be intentional about health equity work within your own programs, among your grantees, contractors, and partners. And I would argue that all of you are privileged because you have access to internet and a device to participate on this webinar today. So I encourage you to use your privilege, the privilege of being a government employee, the privilege of understanding 340B policy, 340B savings and revenue potential, the privilege of being white, the privilege of directing resources, the privilege of creating MOUs, giving guidance and setting expectation. Use your privilege, as many privileges as you have, to work towards health equity. Health department viral hepatitis programs are not hospital systems. I know we don't have the infrastructure, the resources, the staff, the patient volume, or the decades of 340B business experience. But let's break it down. Let's break down the inspiration provided in 340B Health's report, and let's break that down into digestible chunks. So I'm going to end polling, share results. I'm so glad most of you know how privileged you are. I'm glad we're all on that same page. I don't know if you can see the results, but 94% of you have recognized and identified with your privilege. Now you just have to reconcile that privilege. Okay. All right, so now that we've overwhelmed you, I've called you to moral action. Let's talk about what you can do. First and foremost, know your health disparities. Know them, communicate them, educate your partners on them, know your systems, know your struggles. All of this will drive your work. In the examples throughout 340B Health's report, data had to be collected in order to identify and address health disparities. What can you do within your program among your contractors to gather additional data? You can leverage a 340B drug pricing program partnership to examine quality, outcomes, and equity in care patterns. Program savings or revenue can be used to improve systems, purchase software, hire an epidemiologist or data scientist. All of this falls under the scope of the grant and supports grant activities. You need infrastructure to implement any effective programming. Atrium Health transformed how it collects race, ethnicity, language preference, sexual orientation, and gender identity data. They gave additional training and reduced the unknown category to 2%. What would you do if your surveillance data actually told you something and wasn't 40% unknown in a risk category? That would be life-changing, right? I also encourage you to be like Rush University System for Health in Chicago and center communities of colors in your work. Model inclusion on all levels. If someone is missing from the table, bring them to the table. Rush formed a diversity and inclusion working group in 2007 to inform and guide senior leadership in accelerating diversity across the medical center and university system. Their mission has evolved, and accountability steps and measurable goals have also been added. Many of the hospitals throughout the report also have health equity and strategic plans. Does your agency have a health equity strategic plan? If yes, what is it? If no, why don't they? Do your covered entities have health equity strategic plans? Ask them. You could even talk to them about submitting a health equity strategic plan as part of your 340B partnership in order to describe how they plan to address health disparities among their patient populations. Remember, the design and intent of the 340B drug pricing program is to serve the underserved and stretch federal resources. You need to push this on all fronts in all conversation. Atrium Health instituted a call campaign. This speaks to increasing outreach efforts and health communications. Atrium Health ensured accuracy in the language it used in the campaign and individually engaged folks who had previously declined colonoscopies over the phone. How could 340B savings be leveraged to reach the population served by viral hepatitis programs, or more importantly, missed by your viral hepatitis programs? Could the savings or revenue be used to hire an outreach worker? What about more case managers? What about linkage to care coordinators? You need to think in terms of systems here. More what you can do. You can support scientific and evidence-based practices, eliminate the use of liver scores to drive treatment eligibility, remove drug use prohibitions. Drug use is not a contraindication of Hep C treatment. Drug use is not a contraindication for Hep B vaccination. An example of treatment discrimination would be a covered entity requiring drug screening or abstinence before initiating Hep C treatment. This is an outdated and stigmatizing practice. Are the covered entities operating under your grant number doing this? Have you asked? Have you had these conversations? It is within your purview to ensure the covered entities operating under your viral hepatitis grant number are implementing best practices. I want to encourage you and empower you to ask these questions. Remember, you are opening the velvet ropes to the 340B drug pricing program nightclub. You are admitting them into the 340B drug pricing program with your financial or in-kind support. You need to make sure their practices are in line with the scope of the grant and also addressing all of the equity concepts we've been talking about today. Social determinants of health affect health outcomes. Folks need economic stability, safe environments, education, food, community, culturally competent healthcare, among so many other things. 340B savings and revenue should be reinvested in programs and in line with the scope of the grant. And that can include a lot of supportive services that are addressing social determinants of health. That can look like a lot of different things to many different programs: food pantries, transportation assistance, incentives, other services. I encourage you to get creative here. You don't need to lock your sub-grantees and covered entities into just medication. How can you think outside of the box and address social determinants of health? How can you link that back to viral hepatitis outcomes? Somebody can't get well if they're hungry. Somebody can't get well if they don't have a place to stay. Henry Ford Health System in Detroit prioritizes incorporating social determinants of health into its clinical programs and provides nutrition education and physical activity. They provide cooking classes, they give groceries, they give farmers market vouchers. They understand that people need to not be hungry to have any progress in a clinical program and have a good clinical outcome. All right, Isabel touched a little bit on intersectionality. I want to dive a little bit deeper into that. Intersectionality is a term that was first coined by scholar and civil rights activist Kimberly Crenshaw to describe the way that all of us live with multiple identities at the same time and may experience oppression on multiple levels. Each one of us can identify with a race, ethnicity, gender, sexuality, ability, class, religion, and age, among many other identifying factors. For any one of these identities, we may be in the dominant group or a marginalized group. People at the intersection of two or more identities that are marginalized experience oppression that is compounded. When we understand how power dynamics work together and start viewing our work through the lens of intersectionality, we create compassion for the specific experiences of individuals. I would also like to take this time to encourage you to take a look at your 340B covered entities. Who are you subcontracting and granting funds to, and who are you providing in-kind support to? Are they diverse? Are they inclusive? Really broaden your thinking on this. According to the National Institutes of Health, the biggest barriers to healthcare access reported by transgender individuals is knowledgeable and culturally competent healthcare providers, followed by financial barriers, discrimination, and socioeconomic barriers. The 340B drug pricing program can be leveraged in terms of addressing both compounding forms of oppression and serving marginalized populations by working to address the root causes. Along with transgender folks, there's also tribal partners that may be outside of the box of what you normally consider as a partnership. Do you know that there are 200 tribes that do not have federal recognition? Isabel educated me on this, and I thank her for that. And the fact that the 200 tribes are not federally recognized affects the health equity of thousands of tribal members. Not every Native American tribe is covered by the Indian Health Service. Don't assume an organization does not need your support. Don't assume that they are covered under a separate federal grant or are already operating under a separate 340B designation. Over the course of the past 4 webinars, I really hope I provided you with enough content for you to critically think in terms of the 340B program and who you provide in-kind support to and financial support. The 340B drug pricing program can really be leveraged in terms of both addressing compounding forms of oppression and serving marginalized population. This should be a consideration when granting access, renewing MOUs, continuing partnerships, and improving programs. At any time, you can interject these concepts. At any time, you can ask these questions. You as a state level administrator have so much power in your partnerships. Who you grant Section 318 eligibility to carries so much power. Use your power for good. Ask the hard questions. Ask about the populations a provider serves. How do they ensure they're culturally competent? What are their continuing education goals? All of the things. Ask all of the things. All right. This is my reference slide for all of the literature that was included in all of my slides and content. Of course, resources as always. And the summary from today really is the 340B drug pricing program should be used to pursue health equity. Viral hepatitis programs and Section 318 administrators are uniquely positioned to support and encourage health equity activities among covered entities. Critically and strategically think of uses for 340B savings revenue and income, and always keep the social determinants of health in mind. And again, when you know better, do better. And with that, we have a little bit of extra time, so I would love to maybe go through some chat items or ask everyone, how they are going to incorporate health equity into their viral hepatitis programs, the 340B program, any nuggets of knowledge or wisdom that you're taking away from today's health equity session.
Thanks, Erin. So now I feel like this is the Instagram live part. I want to highlight a few comments in the chat box. So first from Rachel, I am passionate about wanting to make clear the mechanisms by which systemic racism creates these disparities. So thank you for making the connections. You're welcome. We have a racial equity work group and are starting to center racial equity in our technical assistance calls with funded counties, but are still thinking through how to center it in our contracts and scopes of work. Ideas welcome.
Awesome. Hopefully running through that list gave you some ideas as well, Rachel.
Okay, and then Rachel, jump in whenever you want if you want to comment. Another from Nadine. The outlandish disparity in funding between HIV and Hep C represents part of the structural racism.
Unfortunately, yes. And I think it also speaks to just the stigmatizing health conditions that are across the CDC. HIV has historically got a lot of advocacy. HIV is well funded. Viral hepatitis, not so much. Viral hepatitis comes with its own stigmatizing issues and its own health inequity. So I think part of our learning and part of our learning about the 340B drug pricing program is how can we work with controllable, actionable items. You're not going to fix the federal government. You're not going to fix legislative appropriations. I mean, maybe you are. Who am I to limit you in your possibilities? But right now, today, this year, this quarter, what can you do to work towards health equity? You do have control over who you admit to the 340B program. You do have control over your memorandums of understanding. You do have control over what you ask your 340B covered entity medical providers. You can ask those questions. Do you know their treatment protocols? Do you know the satisfaction survey? What is the patient experience of individuals being served in 340B programs that are authorized with your grant number? Are they horrified? Are they satisfied? Do they feel seen? Do they feel heard? Do they feel any sort of discrimination? That is all within your control. So like I said, we're not going to fix institutionalized racism. We're not going to take down patriarchy, but what can we do on our level within our focus of control? What can we do? So I really like that reframing. It also helps because then it helps you not feel so helpless. Is there something that you can do? And when we were planning the session, we didn't want everyone to just feel very overwhelmed and not have any actionable items, because all day we can preach to you about health inequity and racism, and we all just feel very helpless. But there's actually something that you can do, that you can contribute, that you can measure, that you can make work and progress towards. So I'm hoping that all of the conversation and the ideas and the brainstorming that this session produces gives a takeaway for you.
Absolutely. I think I'm still, when I first learned about the 340B program, I guess my first question was more, I can't believe this program exists. Like that there's an actual need. Yeah, I mean, I guess this country, it's not surprising.
Yeah, and I also think too, I was speaking with a colleague yesterday, and we've identified just a lack in knowledge about the 340B program. That's why we're here. That's why we're doing this webinar series. That's why there's TA requests. There's just a general lack of knowledge, which means there's many programs that are eligible and are not utilizing the program. So if there's potentially millions and billions of dollars to be saved, utilizing this program that folks are eligible and entitled to be using, what can be done with those millions and billions of dollars once the medication costs are saved? What does that look like? Like, that is just a huge untapped potential that nobody really knows the answer to. We can't quantify that potential because that's really never been explored. So yeah, part of including health equity in that work is starting right off from the beginning, before we completely unleash the potential, to have that as a grounding, guiding principle straight from the beginning.
Absolutely. I have a gem for you, Ricardo. I wish you would, if you want to pop in and discuss further, because this is chef's kiss. Folks should consider harm that partnering with an organization can do and choose partners carefully. For example, if you partner with an organization that reinvests savings into their profits, it is not transparent about the use of 340B program income, or reinvests in areas not supported by the health department of 340B, could work against health equity, as funds are not redistributed to support persons who need it.
Thank you, Ricardo. Yes, let's not support the bureaucratic racist systems. Do not allow them to profit. Keep everyone accountable. If you are generating income to serve more white patients, if you are generating income to give profit shares and bonuses and higher salaries to bureaucrats, that is not addressing health equity. So thank you. And yes, Ricardo, if you want to show your face and preach some more, we are welcome to my soapbox. Step on.
Yeah, no, just, I mean, I don't think I have too much more to share, but really, I think it's, I sometimes 340B covered entities will try to claim that they don't have to report program income to you and how they use it. They will try to obfuscate some of the things that they're doing with their program income. And it's really important that when you create agreements with organizations, that you're very clear about what you expect them to do with the program income, and that you monitor the utilization of the program income to make sure that it's invested appropriately, because they're unfortunately, the 340B program income model is a great model, but it can sometimes be harmful, and it can sometimes, like, because there's a lot of money in HIV drugs and hepatitis C drugs and cancer drugs. And in a lot of institutions, they really do view it as simply a way to boost their revenue, boost their profits. And so I think we have to be very careful about who we partner with, and that, that you don't just look at a big hospital system and assume that, well, they have more capacity, they're a better partner, but also look at, community-based organizations, look at organizations that that might be much more likely to actually reinvest things appropriately and report things appropriately and do the right things with the money.
Thank you, Ricardo. Use your power for good, state level administrators. Use your power for good.
Thank you, Ricardo. Nadine mentioned, this series is making me think deep about our partnerships and how to push the equity work further. Thank you. Thank you, Nadine. Okay, ready? Here comes from Tim. The high list prices of direct-acting antivirals among the highest-priced oral drugs of all time have greatly contributed to inequities. The 340B drug pricing program, beyond its ability to generate revenue for programs, has helped bring equity to DAA access.
So let's take those same HIV lessons and make them applicable for other programs as well. HIV has been in the 340B program much longer. I feel like 340B program knowledge is a little bit better. So let's follow our HIV and STD colleagues into the 340B waters, take those lessons learned and improve upon it. Let's do better.
All right, Rachel. Ideally, we would abolish prisons, but in lieu of that, we should be pushing them to start distributing syringes and safer tattoo equipment and to fund peer education.
I like it, Rachel. I think, you know, in talking to different jurisdictions, folks feel different comfortability pushing different things. So if you feel comfortable having those conversations with your partners, go for it. I'm all about pushing all sorts of boundaries. If you know anything about me, I've got a good track record doing that. But, you know, depending on who you are partnering with and the environment that you operate in, have those conversations. You are providing a program, access to a program that will save so much money. There is no bigger motivator than money. We are operating in a capitalistic society. Unfortunately, we're not going to abolish prisons. We're not going to abolish capitalism. But within that structure, how can you push? How can you progress? How can you have something that's beneficial to your populations in granting access to the 340B program? So I love that perspective, Rachel.
Okay, we have a question from Rachel, and I am actually curious, because I don't know the answer. Do people partner with for-profits? I'm assuming we shouldn't give for-profits 340B eligibility at all.
The answer is yes, people do partner with for-profits. And if you go and look in the Office of Pharmacy Affairs Information System, you'll see health systems in there that are also private providers that wouldn't be traditional public health partners. It all goes back to your grant. So in the STD grant, it's very specific that clinical services should only be provided to safety net providers. That same explicit language is not in the HIV grant. So it really depends on what grant is authorizing, what Section 318 grant is authorizing access, and also what that for-profit is doing, what function they're serving, and what kind of public health partner they're being. A for-profit can still serve a public health function. They can still be a good public health partner. There's just additional considerations. Like Ricardo said, you just need to make sure the savings and the revenue are being invested appropriately. So there might be different monitoring considerations if you are partnering with a for-profit or private clinic or not a traditional public health setting. And in some states, a private healthcare provider or a for-profit organization might be your only choice. So one clinic might be it for a 4-hour driving radius. So that one clinic is treating syphilis. They are participating in Project ECHO and treating hepatitis. They are seeing low-income patients. So it's really a case-by-case basis.
Kate Kling asked, did you say HIV or HCV for allowing for profit?
I know HIV for sure, and I haven't read very closely the newest viral hepatitis NOFO 212103, so I can get back to you on that. And if anybody knows, a viral hepatitis administrator knows, feel free to chime in when you're reading your NOFO very carefully if there's limitations on who you can contract or partner with. Ricardo,
so this is Ricardo. I don't know if you can hear me, but we received guidance that it was allowable for hepatitis C, and we actually are planning to do a partnership with a for-profit clinic. And I agree with everything that you said. I mean, the clinic that we're considering has a long history of serving low-income patients, and their providers run our state's ECHO program, and they do it for free, and they've done it for free for years. And they're part of the hepatitis C safety net because of the restrictions on who can provide treatment in a lot of cases. So we've previously gotten guidance that that is justifiable. However, I will acknowledge that I haven't read the new NOFO requirements on that, so I definitely will we'll take another look at that just in case something has changed. But we've previously gotten guidance that that was allowable.
Awesome. Thank you, Ricardo. See, capitalists can be good human beings too. You just need to make sure they're good human beings. Okay, you guys, you know I have one more poll. It's my favorite thing to do to you guys. I want you to answer one question for me. Let's see, hold on, I gotta click all the buttons, launch my poll. How do you plan to utilize the knowledge you've gained throughout our viral hepatitis 340B webinar series? Choice 1, you'll confidently answer 340B questions, share resources and information with colleagues and partners. You'll encourage some grantees to enroll and utilize the program. Enroll your program in the 340B drug pricing program, make changes or improve your own 340B drug pricing program, or nothing, but you've enjoyed the memes and the witty banter between myself and Isabel. And I see 48% of you voting. Yay. Thank you guys for engaging with us. And oh, sorry, Rachel, you can only choose one option. I blame Alex. Just choose your, I guess, top choice.
Oh, I'll be.
Thanks, Tim. We're here. We're here.
Yeah.
Awesome. Well, you guys have been really great. I hope we've increased your knowledge. I hope we have empowered you. I hope we've given you a lot of ideas, a lot of actionable steps to take. And I'm going to share these results. Hopefully you can see the results. So really, this concludes our series. It's been awesome to take time to really build upon these sessions. Oftentimes you'll attend a conference or there will just be one webinar and it's just not enough time to dive into the 340B program. I'm sure there's still questions. I'm sure there's still scenarios we could run through. So I want to also encourage you to reach out to hepatitis@nastad.org if you do have any questions lingering or situations you want to run through. And this is it for our 340B webinar series for now.
For now, this is not goodbye. This is see you later. And please, folks, your TA questions inform our work. So the more you ask, the better we can serve your needs. And by we, I mean Erin and me cheering her on in the background.
Oh, it's been a great group effort. All of NASTAD staff, I feel, bring something unique, and teamwork makes the dream work, especially in the 340B land. If one of us doesn't know, usually the other one has some knowledge or direction or insight. So
this is true. Special shout out again to NASTAD team for all your support, and Alex for your patience and leadership as well. So I'm gonna stop recording.
okay, see you guys.